Good morning, everyone. How's everyone? Good. That's a little quiet. Are you really good?
Yeah.
Okay. I'm on Colorado time, so it's actually 2 hours earlier for me, so you guys need to keep that energy going. So my name is Jacqueline King. I am a practice facilitator with Health Teamworks, and I've had the opportunity to partner with Sarah and the university on this curriculum. So you probably heard my voice on a lot of the pre-work webinar as well as the Module 1 curriculum webinars as well. And I'm just going to kind of transition and kick us off today. So as you can see on the slide, there's no disclosures that we have for the day. I want to just provide a little bit of an overview to Module 2, and I think that the simulation did a great job doing that, explaining population health management as well as HIT enablement. So similar to the skit, we tend to focus a lot of our efforts on the 20% of patients that, of course, require 80% of the primary care healthcare needs and services and practices. But we also have to look at those patients that may be well or may be lower risk and making sure that they get the services they need. So looking across the whole spectrum is really what population health management is. And today is focused on the data that we can utilize, collect, and then implement into the workflow similar to what you mentioned in your day-to-day work to really make sure we're providing the right care at the right time for patients. So specifically today on the agenda, which you should have in your little binders or your handouts, we'll have an opportunity to hear from the Delaware Health Information Network, specifically a broad brush overview of the DHIN services and how they can help support population health management in your practices. And then we'll have an opportunity as well to kind of dive deeper and do what we like to call working sessions. So you get a chance to make sure to utilize and understand how the DHIN services can be applied to your practice and your workflows as well. And then after lunch, we have an opportunity to talk a little bit more about the quality resource and utilization reports. So for those of you that attended the pre-work webinar, you have those already. But that's really a great opportunity to get, again, a broad brush of what are utilization reports, what data is already available to you, and how can you make improvement changes to make sure that your patients are getting the care they need. And we'll spend some time at the end of the day wrapping things up. Are there any questions before we get into the logistics? All right. So importantly, of course, everyone wants to know where's the bathroom and when's food. So if you go out the doors and to the right, there's both the men's and women's restrooms, just past where the entrance was as well. And we'll be having coffee and breakfast snacks, and then we'll have time again to break for lunch. So if you need any time to stretch or stand up, feel free to do so. Take care of yourselves, absolutely. As you probably are aware, we asked you all to bring your computers. They'll be quite important for the working sessions, both for DHIN and then of course for the afternoon. So please know that we have power strips that are kind of connected to the walls. Don't trip on them, we taped them down, but we don't want any sort of hospital visits as a result of a workforce development session. So please know that those power strips are accessible to the table so you can plug in as you need to. I would ask, though, that during the overview sessions, both by Dr. Lee and Doral, as we kick off each respective time, that you do your best to be present. So to that note, what I did do is I wrote down just some general kind of ground rules or guiding thoughts for the day. One of which is a challenge for all of us as we're so plugged in, is to be present and try to engage. You've all done a fabulous job with that so far, and speaking up and contributing. We encourage that to be the case. Additionally, one of the terms that I use very often in trainings is step up and step back. So I tend to be quite a quiet person, so I always have to challenge myself in big rooms and trainings to step up. So asking questions, digging deeper, giving examples, because the more you have questions, likely others do, and your examples are very relevant. So please challenge yourselves to step up. And conversely, if you're someone that's very easy to chatter, be sure to also step back and give space to others. So we'll do a good job balancing that throughout the day. And last but not least, we are in a conference room, so it can feel challenging, but we are going to have fun today. So please feel free to have some humor. Feel free to give examples that are relevant to yourselves and just have a good laugh as might be. Good question. So there is internet. I don't know it at the moment, but I will write it down as soon as I gather that. I thought about that.
We'll write it down on the board, so before the first working session, we'll have it up there on the white paper.
We'll have it up for you, absolutely. Great question. Yeah. Thank you. Another important thing to know is when you signed in at that table out there, you probably saw this funny column that said time in and time out. In the event that you do have to leave early for any reason, we just request that you indicate the timeout. You don't have to if you're going to stay the whole day, which we prefer. And that's simply for the purposes of CME. So please just keep that in mind if you have any questions about that. And we will have evaluations at the end of the day that we'll hand out too, so please be thinking about what we could do better and how we can make this day most applicable to you all. Are there any other questions? All right.
Jacqueline, I had a request too before, sorry to interrupt you, but just before we transition, can we take like a 2-second break before you transition so the healthcare feeder can make their way out and new people can find their seats if they need them?
Yes, happy to do so. So before we get to that point, Sarah, thank you for that. I do want to just share the Module 2 community learning calls. So this information is the same from the pre-work webinar, but you're going to hear it 10 different times in 10 different ways to make sure to save the dates. So one thing that I think is very helpful with a lot of the DHIN work as well as the QRUR reports as well is just that follow-up piece. Okay, maybe I took the first step in using data, but how do I dive deeper? So we have all of the dates set, and please know that the speakers are already there too. So if you have follow-up questions after today, or you have just other things you want to dive into, that's the opportunity to do so. So please feel free to save the dates and let us know if you have any specific questions or topics you want to review on that. So we'll start with DHIN, we'll then go into QRUR follow-up. And for those of you who are very pediatric focused, I have quite a background in peds, so I know that sometimes the data can seem different because you're not always necessarily focused on the same conditions or the same reasons for utilization, right? So I definitely will dive into that on the July 12th webinar. And then the last one is EHR optimization. So what I want to say about that is it's not specific to an electronic health record, but rather how do you optimize the use of your specific health record. So we at Health Teamworks have a clinical health information advisor that typically does that on a national level, so she'll be very helpful. So bring any questions you have specific to your EHR as well. All right. So just some tools for today. You probably brought or have access to your QRUR report from the pre-work webinar. In your binders, there's an action plan. So I'd like you all to pull that out as well. It basically is landscaped like this, and it's broken up by sessions. So we'll say, for example, DHIN working session 1, 2, 3. The intention of this document is that throughout the day you can take notes on some of the key aspects that really resonate to you, or you say, I really want to apply that to my practice. I really want to start to make changes to use and enable HIT. So I encourage you throughout the day, and I'll keep reminding you, to write down some of your learning session takeaways. Because at the end of the day, we're going to take what you've learned and say, okay, now how can I put it into action? How can I develop my practice's next PBSA or Plan, Do, Study, Act cycle to make sure I'm using the data? So other resources are your colleagues. I really appreciate the diverse roles that are represented today. So please, again, feel free to speak up about how you at your clinic do population health management and what your role is, excuse me. So data experts. For all the sessions, we will have actual working time. So feel free, people will be roaming around the room to help you. If you have questions, feel free to call on the wealth of resources, and we'll do an introduction as we get to that session. And then again, your computers, so if you need to plug in, feel free to do so. Great. So let's take that 2-minute break for people to, if you need to get more coffee, transition out before I transition to Dr. Lee. Thank you. She will be providing, like I mentioned, that broad brush overview of DHIN services and things beyond even my knowledge, so I'm excited to learn just as much. So let's all welcome Dr. Lee.
Thank you very much. And let me see if I can get the clicker working here. Yes, very good. So this is DHIN. This is taken right out of our mission statement, innovative solutions that make health data useful. And I hope as I go through the talk today, you will conclude that that is exactly what we're doing. Whenever you offer CME at a talk, there's a whole bunch of CME-ish rules that you have to go through, and one of them is the disclosure of financial interest. So that one was a bit of a poser, because the talk is about DHIN and services that DHIN offers, and I definitely have a financial interest in DHIN because they pay my salary, and that of all my colleagues. So you have been duly notified of my financial interest. But we're also, supposed to be unbiased and generic to the degree possible. And so I will tell you that if you can find these tools elsewhere, you certainly don't have to get them from DHIN. So in a sense, I will be talking in a generic way about tools and capabilities that you need to have if you are going to be successful in practice transformation. And then I will freely acknowledge my bias up front that I think you're better off getting them from DHIN. Let me just ask quickly, how many of you are from small practices with 3 or fewer providers? Okay. And how many of you are 3 to 5 providers? And how many of you are more than 5 providers in the practice? Okay, so it's a good mix. How many of you are affiliated with a hospital or in some way you're like subordinate to another entity? A few. And then how many of you are independent? Okay. And so a lot of what you're going to be hearing about today grew out of our planning work back in 2013 when we got the SIM planning grant. The state got that grant. And we're soliciting input from the healthcare community, patients, providers, hospitals, payers, nursing homes, special needs groups of various sorts. And what we heard from the provider community was this. In Delaware, 75% of practices are independent and would like to stay that way. And 75% of practices are small, 3 or fewer providers. And so the concern was, to be successful in this new world, you've got to have some technology tools. And technology is not free. And everybody was saying, look, this at EHR incentive program, my EHR is killing me. It's the biggest line item cost in my practice. And yes, I was supposed to get all this money out of the EHR incentive program, but it hadn't actually worked out all that well. I'm still paying a whole bunch of money out of pocket that I'm not getting reimbursed for. And now you're throwing all this other technology stuff at me. Where's the money for that going to come from? And there was a real concern that the small practices don't have the capital to invest in some of these tools. And yet they were looking at, is our only hope of survival getting acquired by a hospital or some kind of a health system? And so that's part of the role that DHIN plays here. We believe that just like all these years, the community health record has been a shared resource across the state so that the financial burden of providing it does not fall on any one entity. That as the need for these other technology capabilities is becoming more and more important for success in a practice transformation environment, that if DHIN can provide technology resources that are shared broadly across the state, then the cost of those services can also be shared broadly. So that's my bias, and I acknowledge it freely up front. It is possible for you to get these capabilities from other sources, so DHIN is not the only game in town. I just think we're the best. Okay, so that said, this is me, who cares? I always was like, do you really want to take 10 minutes out of this presentation to hear all about the speaker? It's like, okay, if you need a piece of paper to tell me that I'm worth listening to, I need to just shut up and sit down. I hope that you'll figure that out yourself by the time the talk is over. Or if not, I really do need to go sit down. Okay, so just a little bit of background here. DHIN is a statutory entity, meaning we were created by an act of the General Assembly of Delaware. In 1997, that's how long ago DHIN got started, at least conceptually. And by statute, the purpose of DHIN is very broad. It's to promote the design, implementation, operation, and maintenance of facilities for public and private use of healthcare information. That is pretty broad. And the powers and duties of DHIN, as set forth in statute, are pretty expansive. You see the list there. We've got all the powers of a not-for-profit corporation under the corporation laws of Delaware. We are supposed to be communicating clinical and financial information, that's right there in the statute. Monitor community health status, that sounds a lot like population health to me. Be a reliable source of information for consumers and purchasers. Promote efficiency and improved communication, and the statute goes into, between doctors and hospitals and pharmacies, and it's basically across the entire health ecosystem, right? Promote that improved communication. Work with governments and other states to integrate into or with the DHIN and/or assist them in forming what amounts to a RIO, a Regional Health Information Organization. And we have done that. And to develop or design other initiatives in furtherance of DHIN's purpose. Okay, so by statute, we are to function as a business, as a not-for-profit entity, but we are not actually incorporated because we are created by statute and we, pardon me, are considered a public instrumentality of the state. The governor appoints our board of directors. The Attorney General's office represents us for our legal needs, but we are not state employees, and best of all, we are not under state procurement rules. So we can actually get stuff done, which is kind of okay, just a little bit of historical context, and I really don't want to belabor this. You have copies of the slides, or we'll have, and so you can read all the details yourself. I really wanted to call out sort of the things that I've circled in red. I've sort of divided DHIN's history into four broad epics, the epics of DHIN. Initially is the formation. I told you that our enabling statute was signed in 1997, and there was a really prolonged period of just thinking through how can this thing work. It had not been done before. We were the first state to to have a statewide operational health information exchange. It had been done in smaller circles before, but this had never been done on a statewide basis, and DHIN was the first. So there was not a roadmap for this. There wasn't a playbook. We made it up as we went along, and this was before high tech, before the EHR incentive program and meaningful use, before ONC, before everything, almost before dirt. Thank you. So it took a while to work through the trust arrangements between the different participants, to work through the consent model. You got to bring consumers into that and say, are you okay with us sharing your data electronically? The answer is they were going, you mean you're not doing that already? Because we're doing that everywhere else in our lives. And so just parenthetically, we do have an opt-out consent model, which means by default, we do share information about patients for purposes of treatment, payment, or operations without having to individually, one by one, get their consent to do so, which is allowable under HIPAA. Some states have an opt-in policy. that says, no, each and every patient must individually, affirmatively say, it's okay for you to share my data electronically before they'll do it. And surprise, surprise, those HIEs have struggled. But we have the opt-out that says a patient who does not want their data shared can come to us and say, don't do that, and then we will take the necessary steps to mask their data so that it doesn't get shared, but otherwise it does. So part of what was happening also in that formation period was a prioritization of what services what are we going to start with? Because you saw the statutory purpose and powers and duties, and it's really, really broad. It's almost anything that touches healthcare information in any form whatsoever. Where do you start? And so we did do a survey of the state to say, of the many different things that could be done through a health information exchange, what are the services that the potential participants would actually value and use? By far and away, head and shoulders, light years ahead of every other thing, was electronic delivery of clinical results, especially labs. And remember, this was back before everybody had an EHR. Right? In 1997, not that many practices actually had an EHR. Even in 2007, when we went live, it was probably less than 20% of practices in the state were using an EHR. And yet, the consensus of the practicing community was, it takes too long to get the results of stuff that we order. It would be really nice to be able to have access to that much more quickly. And then the ability to easily share information that was gathered somewhere else, so that you're not spending so much time on the phone or faxing stuff all hither and yon. If there was one place that you could go to just find everything, those were the services that were clearly most deeply valued. So that moves us into the period of capitalization. In 2007, we went live as a first statewide operational clinic HIE. However, we did that. Where do you get the money to do the technology, right? So it was a combination of three sources. One was a contract from the Agency for Healthcare Research and Quality, AHRQ, under the State and Regional HIE Demonstration Project. So that gave us an infusion of capital to go out and do an RFP and acquire technology. But we also had a 5-year commitment from the state to provide us with 5 years of capital funding to the tune of $3 million a year. I take that back, it was $9 million over a 5-year period. And the caveat was we could not draw down money from the state until we had acquired dollar for dollar matching from private sources. So the intent all along was, this is a public-private partnership. There has to be a commitment on the private side to pony up the money that will make this work. And the state would match during that 5-year period of capitalization. That was the commitment that the state made. So by plan, in 2010, the statute was amended to spin DHIN out from under the healthcare corporation, require it to function as an autonomous, not-for-profit business. The statute explicitly called for hiring a CEO as the principal officer of the DHIN. That would be me. So I came along in March of 2011. That's when I came on the scene. And then within 6 months of my hire, we were to deliver to the General Assembly and the governor a business plan that shows here's how DHIN is going to be sustainable beyond that period that the state had committed to support us with funding. So that takes us into the period that I'm calling sustainable business. And during that time, we focused primarily on execution of the HIE cooperative agreement, because by this time we've got high tech, we've got grant money, we've got the EHR incentive program and a lot of stuff going on with that. So anytime you got a grant, boy, that just consumes your life because there's so many things that you have to do for the grant. And then we were looking at driving adoption of the early services and a modest expansion of our service lines. But it was mostly really, we need to get all of the data sources contributing data to the network, and we need to get all of the practices using the network. And it becomes a self-reinforcing cycle, because I will tell you that in recent years, we have small labs, small data sources coming to us saying, we're trying to get market share in Delaware, and the first question anybody asks us is, do you put your results in DHIN? And if the answer is no, the conversation is at an end. So you are driving demand that is leading more data sources out there to say, if I'm going to survive in Delaware, I've got to put my data in DHIN. So the more data that's in DHIN, the more valuable it is for you to use it. And it becomes a virtuous cycle that reinforces. Well, now we are in the period that I'm calling innovation and expansion. The world has changed a lot since DHIN got started. And with the innovation plan, the practice transformation stuff, there are a lot of market forces today that are quite different than they were in the early 2000s when we were first starting up. And so the state continues to view DHIN as a resource, a vehicle for promoting some of the things that an interest in. In the last couple of years, there have been 6 different statutes that have given DHIN a role explicitly within the statutory language. And then we have a grant right now, which is, we are counting down in weeks until it ends on July 26th. But we've had another grant that has allowed us to develop some new services and begin to launch them. And I'll tell you more about some of those later. So here we are, and a lot going on. But one of the things that I want to stress out of all of that, though, is we have received no capital funding from the state of Delaware since fiscal year 12. The expectation now is that we are delivering services that are valuable enough that people will pay enough to support the service. That's the expectation. We are not getting money from the state. So, other than as they are a customer of services that we provide. And then they pay on the same footing as any other customer using the same service. So here we are. Over the years, you can see the growth in data sources. We started off with just 3 hospitals and LabCorp back in 2007. And now we are up to 136 independent individual sources of data. And that includes over 100 practices that are sending us care summaries at the conclusion of each episode of care. So it has been just explosive growth within the last few years. We've also seen a growth in our services and capabilities. When we launched in 2007, it was one thing, electronic results delivery. In 2009, we added the community health record. And for a good while, that was it. I mean, yeah, we figured out that public health needs some of that data, and we did some stuff to, do public health reporting, and that was important as part of the EHR incentive program for the hospitals in particular. But really, in terms of new, innovative services, it didn't really start until about FY 13-14, and then you can see the growth over time. Now, I'm not going to go into every one of these because we don't have time. You do have, as part of your materials, our current listing of DHIN capabilities and services, and it describes everything. But I'm not going to try to talk about everything today. I'm specifically calling out the things that I believe are particularly relevant to practices that are serious about practice transformation. And I applaud all of you for being here, taking time out of your practice and time out of your work to come to a training session like this is not a trivial investment of your time. and it tells me that you're serious about this. So thank you very much for being here. So at a high level, let's think about what some of the key principles are in the new care delivery and payment models. Oh, my little graphic got moved. How'd that happen? So one is panel management. We've already heard some discussion of this in the theater this morning, right? So being able to do risk stratification and know who your highest risk patients are. And I always say, risk of what? Just saying high risk doesn't mean anything unless you know risk of what. So are we talking about risk of death? Are we talking about risk of hospital admissions? Risk of, I don't know, risk of something. But you kind of know who they are. It's kind of like pornography. I can't define it, but I know it when I see it. You sort of know who your high-risk people are. And then proactive management of especially your high-risk patients, but we'll get to population as well. You saw the phone call. You saw Carl proactively make a phone call to Flo saying, I know you were just in the hospital. Really, how'd you know that? Well, because we were using this service, right? But I know you were just in the hospital. I've talked to your doctor. I'm sure you have a lot of questions. Let's go over that together. And let's get you in so we can, sit down and make sure you understand everything, right? So that proactive reaching out. A key principle now in the new delivery models is you are responsible for your patients, not just when they're in your office sitting in front of you. You're responsible for them at all times, wherever they are. And so that means you got to know where they are. Right? You need to know that one of your patients just hit the ED, just was discharged from the hospital, just was transferred to a nursing home, just had a walk-in visit somewhere, and you hope to goodness that they didn't mess up your care plan. Just had a telehealth visit with somebody, and do they know enough about my patient to be doing that? Right? You need to know where your patients are. And make sure that the right hand and the left hand are connected by a central nervous system. And that has really been the problem with our healthcare industry for all the years of my life and before. So that's it in the new model. And you can't do that as a solo act. You just can't. There aren't enough hours in the day to do that. So you need team-based care. You need a Carl who is going to make those phone calls, because every doctor doesn't have time to make all those phone calls and still see any other patients, right? But somebody needs to be doing that. And so it really does mean organizing your practice in a way that says, this patient is still my patient even when they go see the specialist, even when they're in the ED, even when they're wherever, they're still my patient. And I need to make sure that there is communication across all those settings of care so that somebody is the quarterback calling the plays for the whole thing. And that's what it's really all about here. Now, another key principle in the new delivery models is access management. So why do patients go to walk-in clinics? Why do they go to the ED? Why do they do telehealth? They can't get to you. Or they can't get to you conveniently. And so a key principle is you got to make it possible for patients to get to you. And there's a variety of ways that can be done. It can be done with extended hours. It can be done with reserving some walk-in appointments every day. It can be done by expanded telephone access. I want to tell you, telehealth is a really exciting new thing. I mean, we're finally getting serious about this as a country, saying every healthcare contact does not have to be face-to-face in an office. When you know the patient, there's a lot you can do over the phone. And so it doesn't have to be a telehealth service, but it could be, right? You could actually sign up to be a telehealth doctor. And that can be a way of filling your time when you've got a no-show, right? So you can declare yourself available for a telehealth encounter during that little block of time. And so there's ways that this can actually be a money maker for your practice, depending on which telehealth entity you affiliate with, right? So we could have some conversations about that. And then secure messaging. Now, I've got to say this. You know, we have been trying for some time to promote the use of direct secure messaging, especially with some of the have-nots that were not included in the EHR incentive funding. So behavioral health is a big group who didn't get any money out of the EHR incentive program. And the post-acute care community, home health and skilled nursing facilities, were not eligible for any funding. And so guess what? Most of them still don't have EHRs. So now in this age of digital communication, how do you efficiently coordinate care, do that quarterbacking across the spectrum? Well, look, direct secure messaging really is the poor man's on-ramp to the digital community. And we've been trying to create a provider directory that we can promulgate across the state that would say, here's everybody's direct address, so that the ED can communicate with the practice, can communicate with the nursing home, can communicate with the behavioral health provider, et cetera, et cetera. Nobody wants to share their direct address because you don't really want people contacting you. I don't know if I can help you then. But one of the requirements under meaningful use and now under MIPS is you got to be able to have secure messaging with your patients. So that is a way of keeping track of where your patients are when they're not in your office, is to allow that secure communication. Now it's got to be managed, right? So everybody is going, oh, patients will abuse that. That's a testable hypothesis. You know, don't just assume it and take no action. And I will tell you that those who have tested it have discovered that you may have a few abusers, because look, that's how the world is. But in the main, patients respect your time. Patients respect the fact that you're busy and that you have others to care for besides them. And they don't abuse this. As a rule, and this is, I mean, we have evidence now. This is not theoretical. So, all right. So referral management is another key component. If you are ever going to contemplate taking on downside risk, you need to know that when you refer a patient out, you are referring them to a high-value location. And remember that value is a function of both quality and cost. So how do you know who the high-quality specialists actually are? Do you have data on their outcomes? You probably know the ones you like. You know, they communicate well with you, your patients seem to like them or whatever, but do you know who is producing high quality outcomes at the most affordable cost? I bet you the answer is no. I mean, I just bet you the answer is no. But if you're going to take on downside risk and be financially at risk for the care of a population, you need to know this stuff. How are you going to find out? And so health IT enablement is also a key principle in all of this. You need data to do this stuff with. And you need the tools to manipulate and understand the meaning of that data. And so this is both clinical and claims, if you're going to take on financial risk, you better get some information about the costs and the cost drivers, right? So this is all kind of key principles involved in the brave new world. So let's talk about relevant services that DHIN has to offer that can help you with some of those things. So we already heard about event notification. That was that notification service that let Carl know that Flo had been in the hospital, right? So subscribers to this service provide DHIN with a roster of patients for whom they wish to receive notifications. Now, if you've got risk stratification tools already, and you can pull out that roster of patients at highest risk and you say, I definitely want to be notified about any event on these patients. You provide us with that panel and then we can move accordingly. What we have discovered to our dismay is that even though one of the requirements of certified EHR technology, everybody had an EHR, right? In 1997, not that many practices actually had an EHR. Even in 2007, when we went live, it was probably less than 20% of practices in the state were using an EHR. And yet, the consensus of the practicing community was, it takes too long to get the results of stuff that we order. It would be really nice to be able to have access to that much more quickly. And then the ability to easily share information that was gathered somewhere else, so that you're not spending so much time on the phone or faxing stuff all hither and yon. If there was one place that you could go to just find everything, those were the services that were clearly most deeply valued. So that moves us into the period of capitalization. In 2007, we went live as a first statewide operational clinical HIE. However, we did that. Where do you get the money to do the technology, right? So it was a combination of three sources. One was a contract from the Agency for Healthcare Research and Quality, AHRQ, under the State and Regional HIE Demonstration Project. So that gave us an infusion of capital to go out and do an RFP and acquire technology. But we also had a 5-year commitment from the state to provide us with 5 years of capital funding to the tune of $3 million a year. I take that back, it was $9 million over a 5-year period. And the caveat was we could not draw down money from the state until we had acquired dollar for dollar matching from private sources. So the intent all along was, this is a public-private partnership. There has to be a commitment on the private side to pony up the money that'll make this work. And the state would match during that 5-year period of capitalization. That was the commitment that the state made. So by plan, in 2010, the statute was amended to spin DHIN out from under the healthcare corporation, require it to function as an autonomous, not-for-profit business. The statute explicitly called for hiring a CEO as the principal officer of the DHIN. That would be me. So I came along in March of 2011. That's when I came on the scene. And then within 6 months of my hire, we were to deliver to the General Assembly and the governor a business plan that shows here's how DHIN is going to be sustainable beyond that period that the state had committed to support us with funding. So that takes us into the period that I'm calling sustainable business. And during that time, we focused primarily on execution of the HIE cooperative agreement, because by this time we've got high tech, we've got grant money, we've got the EHR incentive program and a lot of stuff going on with that. So anytime you've got a grant, boy, that just consumes your life because there's so many things that you have to do for the grant. And then we were looking at driving adoption of the early services and a modest expansion of our service lines. But it was mostly really, we need to get all of the data sources contributing data to the network, and we need to get all of the practices using the network. And it becomes a self-reinforcing cycle, because I will tell you that in recent years, we have small labs, small data sources coming to us saying, we're trying to get market share in Delaware, and the first question anybody asks us is, do you put your results in DHIN? And if the answer is no, the conversation is at an end. So you are driving demand that is leading more data sources out there to say, if I'm going to survive in Delaware, I've got to put my data in DHIN. So the more data that's in DHIN, the more valuable it is for you to use it. And it becomes a virtuous cycle that reinforces. Well, now we are in the period that I'm calling innovation and expansion. The world has changed a lot since DHIN got started. And with the innovation plan, the practice transformation stuff, there are a lot of market forces today that are quite different than they were in the early 2000s when we were first starting up. And so the state continues to view DHIN as a resource, a vehicle for promoting some of the things that the state has an interest in. In the last couple of years, there have been 6 different statutes that have given DHIN a role explicitly within the statutory language. And then we have a grant right now, which is, we are counting down in weeks until it ends on July 26th. But we've had another grant that has allowed us to develop some new services and begin to launch them. And I'll tell you more about some of those later. So here we are. I mean, a lot going on. One of the things that I want to stress out of all of that, though, is we have received no capital funding from the state of Delaware since fiscal year 12. The expectation now is that we are delivering services that are valuable enough that people will pay enough to support the service. That's the expectation. We are not getting money from the state. So, other than as they are a customer of services that we provide. And then they pay on the same footing as any other customer using the same service. So here we are. Over the years, you can see the growth in data sources. We started off with just 3 hospitals and LabCorp back in 2007. And now we are up to 136 independent individual sources of data. And that includes over 100 practices that are sending us care summaries at the conclusion of each episode of care. So it has been just explosive growth within the last few years. We've also seen a growth in our services and capabilities. When we launched in 2007, it was one thing, electronic results delivery. In 2009, we added the community health record. And for a good while, that was it. I mean, yeah, we figured out that public health needs some of that data, and we did some stuff to, do public health reporting, and that was important as part of the EHR incentive program for the hospitals in particular. But really, in terms of new innovative services, it didn't really start until about FY 13-14, and then you can see the growth over time. Now, I'm not going to go into every one of these because we don't have time. You do have, as part of your materials, our current listing of DHIN capabilities and services, and it describes everything. But I'm not going to try to talk about everything today. I'm specifically calling out the things that I believe are particularly relevant to practices that are serious about practice transformation. And I applaud all of you for being here. taking time out of your practice and time out of your work to come to a training session like this is not a trivial investment of your time. And it tells me that you're serious about this. So thank you very much for being here. So at a high level, let's think about what some of the key principles are in the new care delivery and payment models. Oh, my little graphic got moved. How'd that happen? So one is panel management. We've already heard some discussion of this in the theater this morning, right? So being able to do risk stratification and know who your highest risk patients are. And I always say, risk of what? Just saying high risk doesn't mean anything unless you know risk of what. So are we talking about risk of death? Are we talking about risk of hospital admissions? Risk of, I don't know, risk of something. But you kind of know who they are. It's kind of like pornography. I can't define it, but I know it when I see it. You sort of know who your high-risk people are. And then proactive management of especially your high-risk patients, but we'll get to population as well. So you saw the phone call. You saw Carl proactively make a phone call to Flo saying, I know you were just in the hospital. Really? How'd you know that? Well, because we're using this service, right? But I know you were just in the hospital. I've talked to your doctor. I'm sure you have a lot of questions. Let's go over that together. And let's get you in so we can, sit down and make sure you understand everything, right? So that proactive reaching out. A key principle now in the new delivery models is you are responsible for your patients, not just when they're in your office sitting in front of you. You're responsible for them at all times, wherever they are. And so that means you got to know where they are. Right? You need to know that one of your patients just hit the ED, just was discharged from the hospital, just was transferred to a nursing home, just had a walk-in visit somewhere, and you hope to goodness that they didn't mess up your care plan. Just had a telehealth visit with somebody, and do they know enough about my patient to be doing that? Right? You need to know where your patients are. And make sure that the right hand and the left hand are connected by a central nervous system. And that has really been the problem with our healthcare industry for all the years of my life and before. So that's it in the new model. And you can't do that as a solo act. You just can't. There aren't enough hours in the day to do that. So you need team-based care. You need a Carl who is going to make those phone calls, because every doctor doesn't have time to make all those phone calls and still see any other patients, right? But somebody needs to be doing that. And so it really does mean organizing your practice in a way that says, this patient is still my patient even when they go see the specialist, even when they're in the ED, even when they're wherever, they're still my patient. And I need to make sure that there is communication across all those settings of care so that somebody is the quarterback calling the plays for the whole thing. And that's what it's really all about here. Now, another key principle in the new delivery models is access management. So why do patients go to walk-in clinics? Why do they go to the ED? Why do they do telehealth? They can't get to you. Or they can't get to you conveniently. And so a key principle is you got to make it possible for patients to get to you. And there's a variety of ways that can be done. It can be done with extended hours. It can be done with reserving some walk-in appointments every day. It can be done by expanded telephone access. And let me tell you, telehealth is a really exciting new thing. I mean, we're finally getting serious about this as a country, saying every healthcare contact does not have to be face-to-face in an office. When you know the patient, there's a lot you can do over the phone. And so it doesn't have to be a telehealth service, but it could be, right? You could actually sign up to be a telehealth doctor. And that can be a way of filling your time when you've got a no-show, right? So you can declare yourself available for a telehealth encounter during that little block of time. And so there's ways that this can actually be a money maker for your practice, depending on which telehealth entity you affiliate with, right? So we could have some conversations about that. And then secure messaging. Now, I gotta say this, we have been trying for some time to promote the use of direct secure messaging, especially with some of the have-nots that were not included in the EHR incentive funding. So behavioral health is a big group who didn't get any money out of the EHR incentive program. And the post-acute care community, home health and skilled nursing facilities, were not eligible for any funding. And so guess what? Most of them still don't have EHRs. So now in this age of digital communication, how do you efficiently coordinate care, do that quarterbacking across the spectrum? Well, look, direct secure messaging really is the poor man's on-ramp to the digital community. And we've been trying to create a provider directory that we can promulgate across the state that would say, here's everybody's direct address, so that the ED can communicate with the practice, can communicate with the nursing home, can communicate with the behavioral health provider, et cetera, et cetera. Nobody wants to share their direct address because you don't really want people contacting you. Because I don't know if I can help you then. But one of the requirements under meaningful use and now under MIPS is you've got to be able to have secure messaging with your patients. So that is a way of keeping track of where your patients are when they're not in your office, is to allow that secure communication. Now it's got to be managed, right? So everybody is going, oh, patients will abuse that. That's a testable hypothesis. Don't just assume it and take no action. And I will tell you that those who have tested it have discovered that you may have a few abusers, because look, that's how the world is. But in the main, patients respect your time. Patients respect the fact that you're busy and that you have others to care for besides them. And they don't abuse this as a rule. And this is, we have evidence now. This is not theoretical. So, all righty. So referral management is another key component. If you are ever going to contemplate taking on downside risk, you need to know that when you refer a patient out, you are referring them to a high-value location. And remember that value is a function of both quality and cost. So how do you know who the high-quality specialists actually are? Do you have data on their outcomes? You probably know the ones you like. They communicate well with you, your patients seem to like them or whatever, but do you know who is producing high quality outcomes at the most affordable cost? I bet you the answer is no. I just bet you the answer is no. But if you're going to take on downside risk and be financially at risk for the care of a population, you need to know this stuff. How are you going to find out? And so health IT enablement is also a key principle in all of this. You need data to do this stuff with. and you need the tools to manipulate and understand the meaning of that data. And so this is both clinical and claims. If you're going to take on financial risk, you better get some information about the costs and the cost drivers, right? So this is all kind of key principles involved in the brave new world. So let's talk about relevant services that DHIN has to offer that can help you with some of those things. So we already heard about event notification. That was that notification service that let Carl know that Flo had been in the hospital, right? So subscribers to this service provide DHIN with a roster of patients for whom they wish to receive notifications. Now, if you've got risk stratification tools already, and you can pull out that roster of patients at highest risk, and you say, I definitely want to be notified about any event on these patients, you provide us with that panel, and then we can move accordingly. What we have discovered to our dismay is that even though one of the requirements of certified EHR technology is to be able to produce lists of patients, we find that the practices really struggle with being able to produce a roster of patients that they want to receive notifications on. And we've had some practices that wanted to subscribe to the service that we have struggled with them for months, getting on toward a year, just trying to generate a panel of patients. So one of the things that we worked with our vendor on is to say, we got to find a way to kind of make that go faster. And so again, this is a little bit of a crude on-ramp, but let me tell you how it works. As we receive a clinical result in our network that you ordered on that patient, we will just add that patient to your panel. Right? Now that patient may or may not be one of your high risk. So that's the thing that you run into is if we do this through auto subscribe, we don't have any way of filtering it to only be your high risk patients. But it's a way that if you are struggling to produce a list, we can kind of help you with that and get you jump started. Now look, when you get the notifications, my guess is you see that list of names, and there's some of them you recognize very well, right? They're your frequent flyers, you know them. There's others that maybe it's like, oh, really? I don't see him or her that often, right? So just because you know your patients, you probably can do some filtering using your brain rather than having to have technology to do it. But as long as we have got some roster of patients that we can work off of, whether it's provided to you by you or auto-subscribed, then as we receive data from all sources coming into us, we can define events and provide a notification. We bounce that incoming information against the roster you have given us, and we say, oh, there's a match. Here is an event about that patient, and this practice needs to be notified. Now, what are the events that we can notify you about? ED visits is one, so admission and discharge, hospital admission, discharge, or transfers, and now some walk-in clinics. We've got the 5 MedExpress facilities in Delaware, Newark Emergency Care, and Ambient Care are all sending us data now. So for those 5, 6, 7 walk-in clinics in Delaware, we are able to provide you with a notification that one of your patients had a walk-in visit at one of those locations. As a patient, I love the convenience of a walk-in clinic. I love being able to stop by on my way home from work for something that's relatively minor. But as a provider, I shudder about the increasing fragmentation of information that results from that. It just makes the whole problem worse. And if we can get them sending data into DHIN, you can know about those visits. So the patients are happy because they have the convenience. You're happy because you've got the information that you need to manage your population, and everybody's happy. We're also starting to work with telehealth. We've got a contract now with MD Live, which is one telehealth provider in the state, and then we have just recently entered a contract with ChristianaCare for their telehealth solution, which is American Well, that they are providing to their self-insured employee plan. So we will have American Well for the defined population of Christiana beneficiaries, and then we will have MD Live across the state. Now, I know there are other telehealth solutions out there. Some of the payers are offering telehealth services to their members, and we don't have them all. So I'm going to tell you guys, just like you have been very influential in getting more labs and imaging centers to join DHIN, because you tell them, I'm sending my business to data providers that will put their data in the network. So if you're not doing that, you will not get my business, right? And we have literally had some holdouts who didn't want to pay the money to join, who came back to us and said, I'm losing more money by not participating than it would cost me to participate. How do I get in, right? So you have an influence in these walk-in clinics and these telehealth solutions that you can steer your patients toward the ones where you know you're going to get the information that you need to manage their care in a proactive and comprehensive way. And you can then encourage those that aren't in to say, if you want my business, you got to be a part of the digital ecosystem of Delaware, because this is how we work here, right? Paid announcement, I'm biased. Okay, now what's the benefit or the value? Because this is a subscription service. It is clearly documented. There's study after study. I'm not going to quote them all here. We'd be here the rest of the day. That early follow-up after a discharge from the hospital reduces readmissions and therefore reduces costs. So it's better for the patient. And by the way, there's something in it for you too, because altruism only takes you so far when you have to pay the bills. And so there's something in it for you. The transitional care management E&M codes that were introduced by CMS a few years ago for Medicare billing will actually pay you money for these early follow-ups. You've got to contact the patient. Someone from the practice has to contact the patient by phone or some method within 2 days of discharge. And you've got to see them face to face within either 7 or 14 days, depending on the acuity of the problem. And depending on which, the acuity is how much money you get also, right? So now, like everything, there's rules about what you have to do in order to correctly bill for that. But there's a lot of guidance out there. You go online, just Google Transitional Care Management Medicare reimbursement codes, and you will get a flock of information about the things that you have to do to correctly apply these billing codes. And I will tell you that Medicare has estimated that the typical family practice could increase their Medicare billing by 4% a year if they consistently use these codes. I don't know how your margins are, but most people would find a 4% increase in their Medicare billing to be a tangible benefit. So I'm pretty sure it would more than pay for the cost of subscribing to event notification. So that's one. Just to show you quickly a little bit of data on how we're doing in Delaware, we have some payers who have subscribed to event notification because they have under contractual obligations as a TPA to an employee health plan. They are required to provide care management services. So, for example, for the state employee benefits program. So we've got quite a lot of notifications that are going to payers, and then we've also got a lot that are going to practices. Our best estimate, and it's always a little bit of Kentucky windage in this, but our best estimate right now is about 17% of Delaware providers have subscribed to this service. Not a trivial number. I'd really love to see it be more, though. And what matters even more to me is that when we look at the roster of patients on all of these notification rosters, 65% of the residents of Delaware are on somebody's roster, which I think is pretty cool, but I'd love that to be 100%. I would really love it to be that nobody in the state could be discharged from a hospital and somebody not get notified about that, right? That would be the ideal. 100% is an elusive goal, but we can get closer than this. Okay, another service that I want to talk about is CCD exchange, or care summary exchange. We're using CCD just because it gets really burdensome to forever say care summaries following the CCDA standards. It's like, let's just call it CCDs and know that that's what we mean, right? And so again, practices that are using certified EHR technology by definition have to be able to produce care summaries in the CCDA format. So if you are using certified EHR technology, you can do this. Don't know if you are doing it, but you can do this. And for meaningful use, those care summaries must be exchanged with other providers at transitions of care. Now, when the stage 2 rules came out, they were real specific that you had to be using direct, and there was some rules there that frankly outraged the HIEs, because we said you've disenfranchised us altogether. You've written rules that make it impossible for the practices to use us to achieve those goals. And since then, ONC has backed off on that a little bit, and so it's a little different now. But you do have to produce the care summary with certified technology, and you have to transmit it using standards that ONC has approved. Now, one of the nice things is you can, working with your EHR vendor, elect to have a care summary automatically created at the conclusion of each encounter. And every EHR kind of has an operational or a technical definition of when an encounter is closed. Whatever happens in that EHR that represents, this is the doctor's signature on that note, it is now a done thing, right? That can provide a trigger to create the care summary and automate sending it to a designated endpoint. And we would dearly love for that designated endpoint to be the Delaware Community Health Record, because that means in the background, with no extra action on your part, it is in a place where it is accessible to any provider who is going to see that patient forevermore thereafter. We right now have over 1 million care summaries in the community health record. Now, we only have about 13% of providers in the state sending us care summaries. And so what that really means is for any given patient sitting in front of you who came from another practice, there's still 90% probability we don't have care summaries on them. And unfortunately, that means that the word has not really gotten out broadly yet that, hey, you can check the community health record to see if there is ambulatory data available on your patient. Look in the documents tab. Lakeisha will be showing you how that works after a while. So now what's the value in this? Well, it can support your meaningful use stage 2 and 3, and your MIPS, Advancing Care Information category, which replaces meaningful use for Medicare eligible professionals. If you're a Medicaid provider, you've still got meaningful use. If you're a hospital, you've still got meaningful use. MACRA and MIPS replaced meaningful use for Medicare eligible professionals, right? But either way, they have very similar requirements. The advancing care information requirements under MIPS are almost exactly the meaningful use requirements. So you are expected to provide a care summary generated by your certified EHR technology and provide that at transitions of care. So whether that's a referral to a specialist, whether that's an inpatient admission, whether that's somebody's going to the nursing home, at transitions of care, you need to be able to provide that. You also have to provide patients with a summary of their visit. Well, one of the things that I'll be talking about a little bit later is just like you appreciate having one place to go to access all of the data on your patients, the patients are really frustrated at having a separate portal for every practice and every hospital that they do business with. And we have heard it directly from the lips of patients. I see 7 different doctors. I am not going to log into 7 different portals to get my data. I can barely remember 1 login. I can't remember 7. They all look different. They all work different. I can't figure it out. And so the very people who could most benefit from having access to all of their data and being able to keep it in one place are the very people who see multiple providers and therefore are not very likely to actually be curating their own records in the way that we would encourage them to do so that they can take ownership of their own health and their own care. And so we are standing up a statewide patient portal, and I'll talk more about that in a bit. But if you send us your data, then we can make that available to the patients along with all the data that we get from the hospitals, the walk-in clinics, the labs, the imaging studies, all the rest of it. Those CCDs can become a part of that data repository that we can make available to patients with one login so that they can get it all. Now, this is a place where if you have already stood up a patient portal, I'm not telling you to throw it away unless you don't like it. We deliberately architected this portal so that there's 3 possible on-ramps. I'm sort of skipping ahead, but I'm going to just go ahead and do that. So one on-ramp is you've already got a portal and patients are using it. Hip, hip, hooray. Let's set up an API call from your portal to our data repository. So when the patient logs into your portal, they get not only your data, but all of the data about them in the DHIN network, all of it. One login, all of their data. Now we would have to work with your vendor to set up that API call, but if they have the capability and the willingness to do it, that is a way for you to provide this access to your patients. And so then the message can be, they want a summary of the visit. It will be in the patient portal, and encourage them to look for it there. Now look, if they still say, but please print out a copy, okay, print out a copy. Make the patient happy. That's what you need to do. But this could be a way, if you are sending us CCDs automatically, no extra clicks, no extra steps, automatically sending it at the close of every encounter, it may reduce workload at your transitions of care, and it may reduce workload at providing patients with a summary of each visit, right? And we hope soon to become qualified as a qualified clinical data registry that would allow us to take the data that you send us, generate your clinical quality measures, and report them to CMS. Now, we're not there yet, so I don't want to do false advertising. We couldn't even start developing that capability until we had some CCDs to work with. And Angie Kaiser, who if you haven't met, you will shortly, we have hired as a clinical nurse informaticist to really help us with this type of work and making sure that we are getting the maximum value for you out of data that you send to us. So why would it be worth your while to spend money on this service? Think about whether the benefit that I've described is worth it. Now, what is it going to cost? Right now, nothing. Because some of this we are still working on. So we are extending a no-cost free trial at a minimum through December. We were doing it under our grant. Our grant ends July 26th. We feel like we're not quite yet at a place where we're delivering enough value that we can charge you money, because we really want to make sure that you are getting value that is worth what you're paying. And we don't think we're quite there yet. I think if we had, there's a phenomenon of critical mass. If we had more than 13% of practices sending us data, how much is the tipping point? I don't know. But it's probably more than 13%, right? That would make this like a known thing that everybody knows. Oh, look in the community health record for that data. And I should be putting mine there too, right? Because that's where people look. So we're going to give this a little bit more time. And so through December, and I don't know if we'll take it beyond then or not, but at least through December, we will not be charging anything for this. That said, I must tell you that your EHR vendor may have charges that we can't address that. But there will be work that has to be done to configure your EHR to automate sending these things to us. And there may be some fees associated with that you would have to work out with your EHR vendor. And again, you'll just have to think through, is what I pay for this worth what it will save me in churn and other work, down the road? I mean, that's a calculus that you have to do. How am I doing on time? Ooh, gotta go. All right, I already mentioned direct secure messaging. I won't really belabor this a lot other than to say it is the ONC standard nationwide for secure, HIPAA-compliant, point-to-point exchange of personal health information, protected health information. So you think about all the combinations and permutations of healthcare entities that need to communicate with each other, and direct secure messaging is a viable and useful protocol for doing that, and it's the ONC standard for doing that. Now, there's lots of other secure messaging solutions out there. There's Zix, and there's dozens. ONC's standard for exchange of protected health information is direct secure messaging. That's it. And I think probably most of you know about this. It's similar to email. You have to send your message to a specified address, so you got to know the address. It's kind of like I could call you on your phone if I only knew your phone number, right? And you can put attachments on it, so you can attach a care summary, or you can attach a copy of a lab result, you can attach a copy of an image, you can attach all kinds of things if your EHR lets you, because not all of them have fully implemented the direct specification. Epic in particular, I believe, will only send a direct message if it has a CCD attached to it. That is the only thing they will send. All right, so if you're using certified EHR technology, you must have this ability, but not all practices have implemented it and are actually using it. So, and then one of the things that we find is you might be using it, but you don't call it direct, because it's sort of baked into your EHR, and you just know that there's like messaging capabilities in your EHR. And when we use the term direct secure messaging, we get these blank stares. You may be using this already as part of your EHR. As I alluded to earlier, the beauty is that WebDirect makes this capability available even to entities without an EHR. So those behavioral health practices, one of the things we're trying to do here is better integration between primary care and behavioral health. How do you exchange information? That's the big problem. You're operating in silos. And direct secure messaging can really be a valuable way to exchange protected health information. And there's special rules around behavioral health data. So there's like, should we put that in the community health record? Yeah, we'd like to, but we don't know. And there, special permissions. And by the way, most behavioral health still doesn't have EHRs, right? So how are you going to communicate and make that integration work? I would really encourage you to think hard about this. Now look, this is going to involve workflow change, right? This is a new tool. And so you and your exchange partners are going to have to think through, how are we going to do this? How are we going to make this work? But it's an important tool. So we are offering it. DHIN is offering this as a standalone service through June of 2018. Right now, our adoption has been very low. And if we don't get greater adoption, we will discontinue this service. We built it and they did not come. Let's tear it back down again because we can't afford to maintain it. But I really hope that we will see more uptake about this, and you guys may not be the ones who need it, because if you've got it in your EHR, you do not need it from DHIN. But your exchange partners may need it. So the nursing homes, the behavioral health organizations, maybe communication with the payers, right? Think about all of the places where you have to exchange health information and the ways you do that now, and think about if those entities had a direct address, would it simplify the work associated with that exchange of information? And if so, have a conversation with them about, would you be willing to consider adopting this tool, and send them our way, because we are not charging for this right now. We had some external funding to support this through June of 2018. So, all right, moving right along. Analytics is another service that we have begun to offer. Some of you, I hope, are familiar with the Common Provider Scorecard that is a part of our state innovation model. Again, one of the things that we heard from the provider community when we were doing our planning back in 2013 was, all of the payers that we work with have quality measures that they grade us on. And you're all looking at sort of the same stuff, but you measure it different ways. And we end up with scores of measures that you're all grading us on, and no one can keep track of all of that. And no one can focus on that many performance improvement initiatives at once. So we feel like you're just using this stuff to beat us up with. Could everybody come together and agree on a common set of quality measures that really matter in this state with our population of patients? I don't really care what's happening in Iowa or California. We're in Delaware. So don't pick generic nationwide metrics, pick metrics that matter here. And everybody pick the same ones, and then maybe we can actually concentrate on doing something about making that better. So, a lot of work, a lot of conversations, came up with now 26 measures that are a combination of clinical quality measures and utilization measures, and then there's some cost of care measures also added on to this. And we got the major payers in Delaware to agree that in their value-based contracts, they would use those measures. That was a major achievement in and of itself. I think Highmark is using these 75% of these, and then they've got a few others that they've still added on. But Aetna and United are just using these. So, pretty cool. Now, we DHIN have produced a scorecard place that you can log in and see your performance against these measures. We haven't had real high uptake of this, and I think part of it is you may not know that whether or not you subscribe to the scorecard, these are actually the measures that you're getting graded on. That this is how the payers are in fact paying you. And so you might want to think about subscribing to the scorecard. Right now, the cost of this is being borne by the State Innovation Model Grant. I frankly don't know what will happen when that grant ends, because it will really depend again on, is anybody finding enough value in this tool that they will pay what it will cost to allow DHIN to keep providing it. We're also starting to think, though, about whether this might sort of morph in some slightly different directions, because one of the things that we discovered in doing the scorecard work is if you do just a simple scatter graph and plot where each and every practice in Delaware falls in terms of the percentage of their eligible patients, in other words, the percentage of those in the denominator that are in the numerator of each measure, you would not believe the spread. It is shocking to me, the spread, the range in quality across this state. I'll tell you what, if you're ever contemplating taking on risk-based contracts, I want to know by name who are those guys down in the low end of this, because I'm not sending my patients to them, right? So there's some thought about, might the scorecard morph in a different direction that would provide value in different ways, but all of that is yet to be determined. Okay, I gotta wrap up. Okay, we do have the ability to offer standard and ad hoc reports, and I think as we move into the demo section, I'll let my colleagues talk more about that. The healthcare claims database is still a little bit of a gleam in its daddy's eye. The statute in authorizing this was enacted last legislative session. The statutory purpose of the claims database is the triple aim, population health research, to support providers who are entering into risk-bearing contracts, and, wait for it, public transparency. The data collection regulation we expect to be released for public comment in July. It will be followed by a data access regulation. I don't have a date yet on when that will be out for public comment. We expect, good Lord willing, and the creek don't rise, to begin data collection in February of 2018. Now, implementation of this is contingent on convincing the DHIN board that it is sustainable financially. So there's still some uncertainty about this, but the idea here is that financial data that was always a part of the vision for DHIN needs to be, we need to gather it. And the state chose to put this claims database within DHIN in order to leverage existing technology resources and existing staffing resources, and leverage the existing governance that DHIN already has, which is already representative of the broad spectrum of the stakeholders. We have some customer service tools. I already mentioned the patient portal. I'm really not going to go into these others. You've got the handout that describes all of these, and Lakeisha may be going into some of them in more detail. So I will just blitz right past that. And this is the end. So this is really kind of our vision for DHIN, that we are way more than just the community health record and results delivery. We are a complex ecosystem, a health information ecosystem. And the intent and the goal is that everybody both contributes and receives value. That little ecosphere is sitting on my desk. Those 4 little shrimp have been merrily swimming around in a little globe on my desk since March of 2012. And the ecosphere stays in balance because nobody takes out more than they put in. And that's the way it's got to work in the network as well. everybody needs to both contribute value and receive value, and there's many ways that can happen, and that's a whole philosophy, and I'll save it for a cup of coffee. So, should I take questions, or should we go right into the demo?
Yeah, great question. So, first of all, I'd like to say thank you to Dr. Lee. That was very engaging. You definitely reeled us all into DHIN. Thank you so much. Rather than take questions just for time, I think we can take a few minutes to actually do a few things, one of which is a bio break for those that need it. And we'll take questions either throughout the working session or afterwards, if that works. Is that okay with you, Dr. Lee?
Perfect.
Great. So let's take a couple minutes for a bio break. And also, this is a great opportunity. We did post the internet information on both side walls. So feel free to bring up your computer, make sure you're connected, so that way you're ready for the next session. That was great. Thank you. I appreciate it. Apologies for